Hey everybody, welcome back to the channel. This is Khara CrossFit Brindle, and I have a familiar face. Ashley is with us today. Hi Ashley, how are you?
Hey, good. How are you?
Doing awesome. So, we always love to talk about like the hot button topics. So here we are yet again on another video, this time about diagnosis. So to kick us off, Ashley, what do you want people to know about diagnosis, especially as a Medicaid provider?
I think in general, a diagnosis is a big label, especially some of them in the mental health field that can follow clients forever. And so one, ensuring that we are accurately diagnosing, but two, that our clients are aware of what our clinical judgment is and why, and that can include what their diagnosis is and why we diagnose them with that. And then three, how does their treatment plan correlate to that diagnosis? How are we helping them, right?
Yeah, absolutely. So Ashley and I are both professors and we teach students. So this question comes up a lot because there's this natural fear of like, what would the client's reaction be to this diagnosis? And although I hear my students, and I think you hear your students, I'm also like baffled by like, why wouldn't they want to know the label you've given
Right,
them?
right. Mhm.
So as someone who's had my own therapy and knowing my diagnosis at the end was felt really important, there'll be clients that we work with that also feel like it's very important. But from the Medicaid standpoint, this is something for folks watching this video who are not Medicaid providers. It's a given that they know their diagnosis because they have to sign off on the mental health assessment, which is the first
Mhm.
intake document we ever do, and
Right.
starts this golden thread, which was Ashley's point number three of like, what is the justification for treatment? How do we move into a treatment plan from here? So as Medicare providers, like we're kind of desensitized to this worry because like we have to share, here's your diagnosis, even if it's going to be changed in 6 months or three sessions in, we have
Right.
more clarity. Like we have to diagnose from the very get-go, which is also stressful. We can name that in this video.
Yeah, yeah, for sure.
Like
And I
I've known
think
you for
too,
60
remembering
minutes.
like part of our disclosure statement is that clients have access to their medical record. And so there's also this idea too, when they sign paperwork of they could ask at any time.
Yeah.
And, if you're hesitant to tell them what's in their medical record, including their diagnosis, what's leading to that hesitation?
Yeah. And so even when I think of clients that I've had that might have had concerns about the diagnosis, like we went through the DSM-5 and talked about the
Mhm.
criteria. We talked about what was coming up for them and what their concerns, like where those came from. And so it can be a really good dialogue and rapport builder. Whereas I think people automatically think it's a relationship rupture. And it's like, well, it
Mhm.
doesn't have to be. It can be a
Right.
chance to like repair and grow
Mhm.
together. So yeah, so like the fear is natural for anyone watching this video, and it's really important for transparency when it comes to client work, and that starts with a diagnosis and any intake paperwork that you have them do. Ashley, what else would you add here?
I think I would add in the medical field in general, when we go to the doctor, we have a diagnosis of some sort. And so also naming that as a client who's using insurance or even a client who's private pay, and that clinician provides a diagnosis. This is how our medical model works. And so this isn't unique or scary to your particular client. This is how our system works. And how can you normalize that this is what we do, and help the client feel comfortable in that way as well?
Yeah. And so, with that being said, clients could naturally have a bunch of diagnoses coming into the work
Mhm.
with us. So, as
Right.
Medicaid providers, it's very normal for clients to kind of bop around or have new providers or have turnover. And so let's talk about the implications of, let's say they have four or five diagnoses that have been given from another provider. Ashley, what are your thoughts in this scenario?
I usually ask clients, do you have a mental health diagnosis and start the dialogue that way? And I would say 75% of the time they say yes, and they'll name one or two or three even. And I ask if that fits. And sometimes clients are like, yes, that absolutely fits. And here's why. And sometimes clients are like, well, what do you mean, does that fit? And then that helps me open a dialogue of, okay, what sort of symptoms do you have? Do you think this diagnosis matches what you've been working on or what you've been experiencing in the past? So I think that's a lovely way to start that. And then my personal clinical practice is really to pare down, what is the presenting problem? And can we really narrow the diagnosis down to one thing? I get really overwhelmed seeing, five or six diagnoses that follow clients. And I know that's part of me and who I am as a clinician when I have new client records. But I also think it's a great place to start, where you're trying to conceptualize a new case of, okay, what is
Right.
going on? What is primary? What is the most concerning symptom? And how is that impacting functioning across areas in that person's life?
Hmm. I love that you asked about fit because that does allow the client to speak their truth of like, well, that
Yeah.
was, a diagnosis I got in a hospital, or that was a diagnosis that they put on me as a teenager when they were listening to my parents more than me, or whatever that looks like, right? So I feel like that can be really eye-opening as a clinician, getting to know your new client.
Mhm.
Um, as someone who takes Medicaid, I've seen diagnoses that are like 6, 7 years old. And so to your
Yeah,
point, it's
me
like, what's
too.
actually in the room right now? Like,
Right.
what's the presenting symptoms in
Mhm.
this moment? And so that's what say to my students all the time is like, what are you noticing? What are you seeing? What are they reporting in this moment? We don't just adopt some obscure list of diagnoses just
Right.
because they had them then, if they don't fit now. What else would you say to students or colleagues who are like, hey, there's a whole list of diagnoses I'm having to consider?
Um, and this isn't a judgment towards colleagues, but a lot of times I don't know the person who's diagnosing them.
Right.
Hopefully there's a name or a clinic name on the chart that you get of like where and when this diagnosis was made and hopefully why, like some justification. Um, but sometimes I get records and I'm like, I have no idea who that therapist or who that doctor is. And I need to make my own clinical judgment because of that. I don't
Mm-hmm.
know how they presented with another provider. I don't know what this provider's expertise is sometimes. And so I don't think it's necessarily ethical to just continue a diagnosis. I think if there's records saying PTSD from 5 different providers over 7 years, it's probably pretty clear, hopefully, that that is a significant piece of this client's presentation. But if there's diagnoses that are kind of all over the board, then that's when I especially really try to work from a blank slate and ask the client to tell me their story.
Right. Right. Which just makes me think of when I worked in like corrections. And it's like if I read their whole file, I'd have this biased opinion of them. But to start with a
Yeah,
blank slate is
exactly.
actually much more
Mhm.
helpful than
Right.
just adopting someone else's opinion.
Mhm.
So that's valid. Which brings us to the point in the video where we're like, the hot button of it all is,
Yeah.
as Ashley just named, diagnoses that you're equipped to diagnose, but also equipped to treat. And
Mhm.
so an ongoing conversation in the Medicaid community is diagnoses that you put on someone and then it's like, okay, are they reflected in the treatment plan and are you actively working on them? Because in
Right.
how we've been trained with Medicaid, if it's part of your treatment plan, it means you're working on it. If it's not part of the
Yep.
treatment plan, you're not working on it.
Hmm.
So this first came up because someone said, hey, I have a client who's consuming alcohol at higher rates than they'd like. They meet the criteria for alcohol substance disorder, and they don't want to work on it. And
Mm.
so I was like, huh.
Interesting.
And I was like, so is that part of the treatment plan or not? And they're like, well, I have it on their treatment plan. And I was like, well, why? They're telling you they don't want to actively work on it.
Hmm.
So obviously, we're opening a can of worms here. Ashley, how
Yeah.
would you navigate this? Because this was just one example. We have two other diagnoses we want to talk about. But like this like broad scope is if the client doesn't want to actively work on this or you're not equipped to work on this particular
Right.
diagnosis, should it be reflected in the treatment plan or not? What are your thoughts?
I don't think it should because my treatment plans have a time frame of
Mm-hmm.
like, when do you anticipate this objective or this goal being closed out? And if you have no anticipation for that objective or goal being closed out, why would it be on the treatment plan? Um, and then my other thought is, what does the client want to work on, right? And if the client doesn't want to work on alcohol, but is able to name, oh, I'm drinking more than I want to, as a licensed addiction counselor, I always want to know why someone's drinking. And I think the
Mm-hmm.
why is usually related to mood dysregulation or stress in other parts of their lives or trauma. And so hopefully that is the main piece of the treatment plan. And there's a diagnosis associated with that. And then I wouldn't
Right.
diagnose with alcohol use disorder
Yeah.
in
Yeah.
that specific case.
That's fair. Yeah. So viewers, hopefully you're just taking this in with an open mind as to what we're trying to point out, which is if we adopt a bunch of diagnoses that don't fit the current moment or are not presenting, or we don't know the provider who gave this diagnosis, that already leads to problems. But then it's what is the client actively wanting to work on in your
Yeah,
care under
such a
your
good point.
services?
Hmm.
So it's like, there's lots of layers here. So I mentioned two other diagnoses that have become problematic specifically to
Yeah.
the Medicaid community, because that's where you and I show up, but
Mhm.
also for anyone watching this that is currently in private practice. So what are those other two diagnoses that we should name aloud?
I'm hoping you're talking about autism spectrum disorder and then ADHD. Those were the
That's
two that came
right.
to my
Yeah.
mind. Okay. Yeah.
You're like, just double checking from when we
Yeah.
last talked about this. Yeah. So let's start with ADHD. Why is this problematic in our community?
I think a couple different things. One is, as an LCSW, I went to school for social work and I was never trained on ADHD. I was never trained on some of the common assessment tools. The Vineland, I think, is commonly used in school. I've never worked in schools, so I don't have that experience either. And I think what's hard too is a lot of clients are coming into our offices now saying, I have ADHD, and you're asking why. And then when you look at the DSM, the criteria is actually very, very, very strict. You have to meet, I think it's at least 6 symptoms across settings during a certain time frame, during a certain age. And so I think my concern with that one is twofold. One is people aren't looking at the DSM and how strict that criteria actually is. And two, you know, impact on functioning, right? Like
Mhm.
as an adult, if you've been fine, I guess, right? If you can work, if you can hold a job, if there's no disruption in relationships, and there's no history of the child, then why are we making that ADHD diagnosis? So
Mhm.
again, that time frame, that age group, and then, the bottom piece of most diagnoses is it has to cause clinically significant distress. And so I
Right.
think that's a piece a lot of clinicians miss.
Mhm. I agree. And I think there's so much overlap between trauma response and ADHD presentation
Absolutely.
that this
Yep.
is always where my head goes of like the Venn
Hmm.
diagram of like, all right, overlap, which is
Yep.
it?
Yep.
Um, the other elephant in the room, from my understanding, is we're not allowed to assess. We're not allowed to test for ADHD as master's
Yeah,
level
I don't.
clinicians.
Mm-mm, I
So
don't.
LCSW, LPC on my side. This is why Ashley and I like to come together to say here are two home disciplines that have the similar challenge. And
Mhm.
so someone might come in saying, I have an ADHD diagnosis, but we can't diagnose that. Like we didn't
Right.
assess, we didn't test. We can look at the criteria to your point, but like for thorough testing has to be done by a doctorate level
Mhm.
provider. And
Yep.
so what are your thoughts, Ashley, on adopting an ADHD diagnosis from another provider? I mean, we're right back to the beginning of this video, which is somebody else gets said this is true. And they're telling us the client says this still fits. Thoughts?
My thoughts depend on what setting the clinician is working in. I think if it's in an interdisciplinary setting where, it's a clinic with a doctor, the social worker or clinician, other sorts of techs, that I feel differently about than, someone in private practice adopting this diagnosis. Um, as a licensed master's level clinician, I would seek out a different diagnosis, to be honest. I would
Mm-hmm.
really tease out with the client, is there mood stuff going on? Is there trauma stuff going on? What is the disruption in functioning? Um, and treat that because I can't treat ADHD. So that's the other piece for me specifically of why I never make that diagnosis because I'm not trained to treat ADHD.
Mm-hmm.
And so I think that's the other piece too, is are you carrying this diagnosis and then treating something else? Are you carrying this diagnosis and then talking to the clients about their week? And it's kind of this maintenance therapy where they're coming in just to talk to someone, or are you treating something totally different?
Mm-hmm. Right. And I recognize there are colleagues of ours that are master's level who specialize in ADHD, and they probably
Mhm.
have certifications and additional
Absolutely.
training to make this
Absolutely.
work. And so in
Hmm.
my mind, I'm just going to run this by you in this video in real time. But in my mind, it's like there's a primary diagnosis and there's secondary and
Yep.
tertiary
Mhm.
diagnoses, if appropriate. Let me say that again. In my mind, there are primary diagnoses, secondary and tertiary diagnoses, and primary is what we're treating because it's our treatment
Great.
plan. So
Hmm.
I have been known in the past to put ADHD as like secondary or tertiary to reflect this is a part of their experience. The symptoms are there. It is part of the DSM criteria, but it's not my primary diagnosis for billing and the focus of our treatment together.
Great. Hmm.
How does that land for you as someone hearing this from me?
I agree with you. I also would hesitate to even put it secondary, but again, that's just my practice. I might put in the intake or the treatment plan somewhere else. This client self-reports a history of ADHD. This clinician is not currently working on symptoms related to that diagnosis. So I want the client to be heard and I want their chart to be accurate, but I might
Right.
not actually put that in as a secondary.
Yeah, yeah. And so for viewers who are hanging in there with us in this video, this is what we mean by it. This is complicated. This is gray
Hmm.
area. Where do the diagnoses land if they're not given by you? If you're not equipped to assess, if you're not trained to assess, if you don't meet the level of education to assess, how
Hmm.
does this show up in your treatment plan? Like Ashley said, we want to reflect this accurately. If this is the client saying, I have a history of ADHD or I have a history of substance use or whatever that looks like, but is that actively part of the work you're doing with them as a clinician? Is it part of your treatment plan? Which leads us to autism as the other hot button for this video. Again, you and I as master's level are not trained and approved to assess for autism.
Hmm.
That's a doctorate level, medical and or psychologist level provider. But then we have plenty of colleagues who are like, I do ABA, I do certain treatment modalities that would fit for autism. So another place for your thoughts, Ashley.
I think a lot of people treating autism spectrum disorder are not doctoral level, and I don't have a problem with that. I think a lot of ABA providers are not doctoral level providers. And so, again, it's the experience and training that I would be looking for. Um, and I think the chart just needs to be clear of this is the problem I'm treating and
Right.
this is where that diagnosis came from, and here's how I'm treating that problem. I think with autism spectrum disorder, there is always going to be that gray area because the people treating that population, um, there tends to be interdisciplinary teams, and usually only one person of that team is the doctoral level person. And so I think again, it just comes back to making sure your documentation is clear, making sure you're treating a problem you are equipped to treat. And then
Mm-hmm.
if it's being covered by insurance and including Medicaid, like how are you working with the insurance company to ensure that you are getting reimbursed for what you are doing and that your chart is accurately reflecting what you're doing and the client knows what you're doing and why.
Yeah, definitely. So I feel like the big message of this video is stay in your scope of practice.
Yes, please do. Please do.
So if you have additional training certifications that allow you to work with autism, ADHD, any other specialty, of course, we're not here to tell you to do or not do. We just wanted to bring up this is coming up in our supervision. This is coming up
Mhm.
in consultation. This is coming up in our Medicaid community. This is why Ashley and I felt called to have a video on this topic because our students are asking it, but also the community is asking how this
Mhm.
is going to land. How do we document this? And I think the big piece is stay within your scope and in your treatment plan, reflect what you're actually going to do with the client. So if you're like, I
Yep.
have a bunch of diagnoses I'm not going to even touch, maybe they're not relevant to put in the treatment plan. Maybe they're in the
Mhm.
intake as part of the history to reflect that accuracy, as
Right.
Ashley described, but not the treatment plan because the treatment plan is what you're doing to get
Mhm.
reimbursed by insurance or to get paid by insurance. And
Yep.
so that I think is where you and I as educators, Ashley, are just like, you're documenting what you're doing. Like, why are they
Mhm.
paying us as providers? Would you say
Yep.
that's fair to put it that way?
Yeah, I think that's absolutely fair.
Yeah. So obviously, this is going to stir up some thoughts in our community because it isn't black and white. It's not don't touch it, do touch it, diagnose, don't diagnose. That's not what we're here to say. We just wanted to like crack open the gray area a little bit and say here are three examples of diagnoses that have caused some confusion.
Mhm.
But also as supervisors, I think Ashley and I can both say like we're just looking at our team, the people we're supervising, to say what are you equipped to do, what's in your scope of work, to make sure
Exactly.
that we're not causing harm to clients in any way, shape, or form. So
Mhm.
that's kind of the big ticket here.
Yep.
Final thoughts, Ashley, on this video.
Final thoughts. If you're confused or unsure or want a second opinion, please seek one out. Ask a trusted colleague, ask someone else who specializes in what you're treating for their thoughts, and don't work on your own. I think it's always great to get feedback and to understand how other people are diagnosing and documenting.
You don't have to know what you don't know.
Yeah,
You can ask
exactly.
questions,
Yep.
go to your community. This is one space to start getting curious about this. Supervisors, maybe you're bringing this back to your teams or to your supervisees or group supervision, whatever that looks like. For individuals, maybe you're just taking a pause on what diagnoses am I adopting from some other provider versus which ones am I reflecting in my treatment plan.
Mhm.
And so that was really the point of this video, is to think about this as a hot button that's coming up in all these different settings. And hopefully this sheds some light on how you're going to critically think about it from here.
Yep.
So we will continue to make videos that hopefully have relevance to the work that you're all doing in private practice. Stay tuned for the next video. We'll see you next time.